All right. Hello, Christine. How are you?
I am well. How are you?
Doing great. What are we going to learn about today?
We are going to learn all about
The brain?
the brain and the nervous system.
Oh, nice. I've always been complimented on my nervous system.
Really?
Yeah. Yeah. All my life, I've been told you got some nerve. And I didn't realize it was a compliment until I started studying this stuff in grad school. So,
Yeah. Wow.
yeah. Um, all right.
All right.
Let's get started with our anatomy and physiology review. We're going to quickly go over this stuff. We're not going to spend a ton of time on most of it. I hope it's a resource for students to look back to when we get into the pathologies. But I say review because with their anatomy and physiologies that they've already taken, they should be familiar with a lot of this stuff already.
Mhm.
So the nervous system is comprised of the central nervous system and the peripheral. The central nervous system is brain and spinal cord. Peripheral is the spinal and cranial nerves. Uh, now, how do we develop this nervous system to begin with? Well, it starts growing the first few weeks of gestation and continues beyond birth. That neural tube forms around 18 days of gestation, begins as an open-ended tube and then closes somewhere close to the day 28 of gestation. And then the brain starts developing. Now, this stuff will be important to understand when we start talking about spina bifida. That's one pathology we'll talk about later that this development, it's directly impacts from that. Um, so with neural development, once the baby is into the world, we get to start testing reflexes. We start looking at development of motor milestones, gross motor and fine motor. And the all of that, if you are a pediatric specialist, I don't care if you're massage, PT, or OT, you're going to understand those reflexes in a much greater detail than I do. I mean, my wife, she's a pediatric PT. She understands them greatly. And the goals when we have those pediatrics is to climb the ladder of milestones, climb the ladder of the motor milestones, whether it's again gross motor or fine motor. You need to be able to sit independently before you learn how to crawl. You need to crawl before you learn how to walk. So we try to just achieve that next milestone with these kids. And sometimes we use these reflexes to either enhance our treatments or we try to avoid those reflexes as they come up. So they are important to know in practice. We don't want to spend a lot of time on it now, though. So do you have anything else to add about that?
Yeah, I'll just add that with the primitive reflexes, the goal for a lot of them is that they get reintegrated. So basically they go away. And sometimes there can be challenges where they're sticking around longer than they normally would. And so an example in pediatric occupational therapy might be that you have a child who is having difficulty with crawling. And you may notice that when they're crawling, if they turn their head one way, then their opposite arm collapses. And that's what's the barrier that's stopping them from being able to crawl functionally. And so that would be because there's a delay in the ATNR reflex being integrated. So that's
Yeah.
an example of what pediatric practice would be. And you would work on ways to help encourage them to get through that milestone.
Yeah, there's a whole bunch of those reflexes. I mean, I'm always amazed whenever I have to look at the list how many there are. And there's simple things like if you rub the cheek of an infant, they'll turn to the stimulus, and it's a feeding technique. There's the Morrow reflex, which I think we talk about in one of these pathologies later, which is the startle reflex. If you ever seen a baby start to fall asleep and all of a sudden everything just like extends and they're startled awake with seemingly over nothing, but there's some sort of stimulus that did it. So yeah, looking to get rid of those anyway. So pretty fascinating stuff here if you're into pediatrics. If you're like me and you're not quite so much, you just say, wow, that's a long list of reflexes. So the anatomy of a neuron, of course, we have the cell body, we have the nerve length itself, and then those nerves, if they're covered in myelin sheaths, they can conduct the impulse faster than without myelin. When we talk about MS later on, we'll talk about the damage to myelin sheaths and how that can start impacting that pathology. I always think talking about action potentials, how does a nerve become stimulated? How does it send its signal down its nerve? It's always good, although probably a little bit more in depth than we want to spend for today. Important stuff for things like our seizure disorders to understand how these action potentials get really, really sensitive and really just go into hyperdrive. So that is important for that. And you had some other ideas on when this basic understanding of the action potential and how these signals get sent.
Yeah, so just in thinking about maybe, for example, working in an acute care setting where people have mineral deficiencies from dehydration and they are needing maybe IV potassium and fluids. So if you look at, for example, the higher concentration of potassium inside the cell being needed to reach that neuron impulse threshold, if a person doesn't have quite enough potassium in their cells, then the transmission of these impulses are not going to be working the same way. So you may see that that person's motor control is affected. But that's something that you would be aware that, you know, as they have these fluids or the IV potassium, that will likely improve.
Absolutely. So again, more action potential details if, again, the students wanted to recap some of that, if that's buried way back in their brain from when they took anatomy and physiology. Nerve synapses and how nerves talk to one another. Neurotransmitters are really important to understand, especially when we talk about medications. I know we're going to talk more about medications in our mental health section later on this semester. We're going to just briefly touch on it when we talk about dopamine and with Parkinson's, but important information to know, and especially how medications can impact those neurotransmitters itself. Now, this is something I want to spend more time with, is the lobes of the brain. This is something that I think 1, 2, 3, 4, 5, at least 6 different disorders that we'll talk about today. You need to have an understanding of each lobe of the brain and what its function is. Because when we start talking about impairments to the brain, we need to know specifically which lobe are we talking about. And even lobe, and we could get even much more specific if we need to. We're going to leave it more on the broad side of lobes, but we could be even more specific than that if we needed to. So Christine, do you want to talk about each lobe of the brain and the general functions of that lobe?
Yeah, of course. So your frontal lobe is going to be more of your executive function planning, also involves in the healthy brain, your personality, intelligence, some emotion, attention and concentration. Those are executive functions, judgment, some body movement, problem solving, again, is an executive function, and speech. So that's the speaking and writing. When there's an injury in the frontal lobe, this can lead to loss of movement, having thoughts repeat themselves, not being able to focus on a task. So a person may need to be redirected back to a task a lot. They might be tangential when they're talking, go off on tangents, mood swings, irritability, their social behavior and personality can change, difficulty with problem solving. So this can look like, you know, if you go to put on a shirt and one of the sleeves is inside out, being able to figure out how to fix the sleeve so you can put your arm through. Difficulty with language, not being able to get the words out, and that's the aphasia. The parietal lobe, so in a healthy brain, it's sense of touch, a lot of sensory pain, temperature, being able to tell the difference between size, shape, and color. That would be something that would be really important, say, for driving. You stop at a red light or a green light. If you have damage to the parietal lobe, being able to tell the difference in the color would be challenging. Spatial perception, visual perception, so that can have to do with navigating stairs or uneven surfaces outside. So the injured brain, difficulty distinguishing left from right, lack of awareness or neglect of certain body parts. So this can be challenging when you tell somebody to grab onto their walker, but maybe they aren't aware of their left side and they only use their right hand on their walker. So then they'll need that extra cue to use their left hand. Eye-hand coordination, difficulty reading, writing, and naming things, and then difficulty with math. The occipital lobe, that one is easier to remember because it's just vision. So this can lead to blind spots in vision. It can lead to diplopia, which is blurred vision or double vision. It can lead to visual illusions or hallucinations. And it's okay to ask somebody who has challenges with their vision what they're seeing, ask them to describe it, because they may describe that there's like twinkling stars in the corners, or sometimes there's like zaps of different color light that they see. And that's what the visual illusions are. And then difficulty reading and writing. So with an example of brain injury to the occipital lobe is slip and fall on ice. So if you think about, if you step outside and there's ice right outside your door, what happens is you put that foot down and it slides forward and you go backwards. So there's a good chance if someone has a slip and fall on ice, they're going to fall backwards and they're going to hit the back of their head. That's going to be the occipital lobe. Functionally, what this can lead to is these challenges with vision. People with some of the blurred vision, or it might be movement, people may have kind of motion sickness when trying to walk around. They can get more tired more quickly from trying to focus their eyes a lot. Sometimes they can be sensitive to light or certain types of lighting. So sometimes it can be helpful to have someone wear a visor if overhead lighting bothers them, and that will actually save their energy and help prevent headaches and things like that.
Also a huge fall risk if you can't see the ground you're walking on, and especially stairs when you can't, descending stairs, you can't visually see when one stair ends and then it drops to the next level. Lots of fall risk problems associated with vision changes.
Yeah, especially if that, what you're describing with the, if there are blind spots and they are in the lower field of vision.
Yeah.
And that's actually a good point too, because the spatial perception is the parietal lobe. And so another point to keep in mind is that injuries can happen in a specific area, but the brain functions as a whole. So a lot of these tasks are actually teamwork. And what they've been able to identify something like over 60 parts of the brain that actually contribute in some way to vision. So it's not just one lobe that controls it, but it's a team effort. So then we have the temporal lobe. So temporal is, I think, of time. So that can be in the sequencing and organization, can be challenges around time. So in a healthy brain, temporal lobe controls speech, and that's more the understanding of language, the memory, hearing, sequencing, and organization. But then in an injured brain, so there would be difficulty understanding language and speaking, but mainly with the understanding of the language. And then difficulty recognizing faces, difficulty identifying and naming objects, problems with short and long-term memory, changes in sexual behavior, and maybe even increased aggressive behavior.
I just want to pause for a little second. So if we look at where the frontal lobe is, there's a highlighted blue area called Broca's area. And then in the temporal area, we have the green area called Wernicke's area. So those are the two big speech areas. And like you said, in the Broca's area, in the frontal lobe, it's the output of language. It's getting that message out to the rest of the world. But in the temporal area and in Wernicke's, it's actually receiving that message. So someone who has Broca's aphasia or an injury to the Broca's area of the brain will be able to understand our cues as healthcare practitioners, understand us completely. They might not be able to get their message out to us, which has got to be really frustrating for that person. But somebody with damage to their Wernicke's area, they're not going to understand us, and they're not going to be able to get their message out because they have no comprehension of that language. So it's important to understand the differences between the two, because it changes how we practice. It changes everything on how we work with our patients with the different types of injuries.
And functionally, if a person, if it's aphasia from the Wernicke's area, and they're having difficulty understanding the language, that can be really challenging in being able to explain or teach them steps, communicating cues and prompts. But maybe you need to start using more of a tactile cue rather than a verbal cue to communicate with them. And then with Broca's aphasia, like you were saying, how frustrating that would be. When I was at a brain injury community program, one of the things that a lot of the members there shared who had Broca's aphasia is that because they just have difficulty communicating what they're trying to say, but they understand, people who aren't aware of the different types of aphasia assume that they don't understand. Absolutely. And so it's really good to be able to pause and let the person respond. And it may take them more time, and don't just give them the answer, but give them the opportunity to work through it. And one strategy can be, if they are having trouble finding a word or the correct word, ask them to describe what it is that they're trying to say, rather than to keep trying to find that word. So it can just be really challenging, because people can be easily misunderstood because they're not speaking clearly. There can be an assumption that there's a deficit in their understanding when there isn't.
Yeah, and a lot of opportunity for family education as well.
And then we have the cerebellum. So that addresses balance and coordination. And we're going to talk a little bit more about the cerebellum when we talk about Parkinson's disease too. There's a really cool intervention that involves the cerebellum. But with injury to the cerebellum, there's difficulty coordinating fine movements, difficulty with walking. There can be tremors, dizziness or vertigo, and slurred speech. And again, slurred speech is actually a coordination, like a motor movement challenge, because it's the motor control of speaking. And then brainstem, so healthy brain, these are just the basic functions: breathing, heart rate, alertness, and consciousness. And so an injured brain, where the injury is the brainstem, this is very severe: changes in breathing, difficulty swallowing food and water, problems with balance and movement, and then dizziness and nausea from vertigo.
Yeah, so at least 6 or 7 disorders that we talk about later will talk about different areas of injury and different types of injury to the brain. So you have to know the different lobes of the brain and their overall functions. And we could go even more in depth if we needed to. And that's just going to help prepare us as practitioners. Someone who has a frontal lobe brain injury versus an occipital lobe, how we would set up the environment, our treatment strategies, our emergency, what can go wrong, how do I want to plan this, very, very different for someone who has attention, concentration, poor judgment impairments versus someone who has visual disturbances. So really important for us to understand. We could dive deeper into forebrain anatomy as well. I don't think we need to all that much right now, but again, it's here for our students to refer back to should they feel like they're lost and where do I go for this more information. Blood supply to the brain once we get to strokes, cerebral vascular accidents, knowing which major artery of the brain was involved could lead us to knowing to be able to predict what symptoms we might see and then also start thinking about treatment strategy for that person. Can be important. Again, brainstem, hindbrain anatomy, going to leave it here for our students for review, but not going to spend a lot of time on it. The cranial nerves, I think, again, goes along the lines of making sure our students have information at their fingertips should they need to. I always think it's fun to learn the anatomy of the cranial nerves. Do you have a mnemonic that you use that is safe enough to share to remember the cranial nerves?
What's yours?
Oh, once one takes the anatomy final, very good vacations are heavenly.
Oh.
So that's how I remembered at least the first letter of all of these cranial nerves. So did you have one? I mean, I remember that from when I was, I don't know, 18 years old, took anatomy as a freshman in undergrad.
Yeah, no, I didn't have one.
You're too smart. You just learned it all.
Yeah.
You need to rely on tricks to remember these things like me.
Yeah.
All right. Something else I want to slow down on is the spinal cord anatomy, because this can be really complicated. So the major things it does is it sends messages. The spinal cord's job is to send messages from the body to the brain, and then it's to send messages from the brain to the body. And then it also houses some reflexes to it as well that don't need to go straight up to the brain. So the spinal cord runs from the base of the skull to the L1, L2 vertebral interspace. From there, it turns into the quada equina, so it kind of breaks off, and quada equina means horse tail. So it looks very kind of frayed almost. So there is the gray matter and white matter. You can see it looks kind of like a butterfly in the center. And we have the nerve roots, the posterior and anterior nerve roots where sensory messages come in, and then they go into the spinal cord, and then they go up to the brain. Now, the thing that always gets students when we start teaching this are the tracts of the spinal cord. Anytime I've taught this, all the students I talk to just get overwhelmed quickly. So we spent a lot of time talking about the brain as a whole, and then we said each lobe of the brain has different jobs to it. And I think that's pretty easy to understand. The spinal cord is the exact same. We have the spinal cord as a whole, but then each area of the spinal cord has its specific job. But instead of calling it a lobe, we call it a tract. And the tract is just simply because it's the highway of that message. So we have all of these funny different names: facilicus gracilis, facilis cunatus, anterior spinal cerebral tract. We have anterior cortical spinal tract. We have ascending tracts and descending tracts. The ascending tracts take signals from the body and launch it up to the area of the brain it needs to go. The descending tracts take it from the brain and it goes to the area of the body that it needs to. So the big take-home message is that the tracts of the spinal cord are a lot like lobes of the brain. And the more you understand the tracts of the spinal cord, the better you can understand injuries to it. And when we talk about spinal cord injuries, and especially when we talk about incomplete or partial spinal cord injuries, knowing the tracks are going to make sense on what are we seeing here and why are we seeing that. So we have a few examples of the primary ascending tracts: anterior cerebral spinal, posterior cerebral cerebellar, spinal cervical, and spinal thalamic. Those are some important ones, and you can see them on the diagram. I think one thing we failed to mention in the brain, the right side of the brain will control the left side of the body. Well, when in the spinal cord, we're going to stay on the same side. So the left spinal cord is going to receive messages or send message to the left spinal cord. We're going to stay on that same side. So that is one thing to understand when we have our primary descending tracts. So I hope this isn't too overwhelming for our students right now. The big take-home message is the spinal cord is a lot like the brain. Just replace lobes with tracts, and then you can understand each tract a little bit more. You'll understand the anatomy better, and you'll understand the physiology of all of these different disorders better. So we'll just keep it nice and broad for now and allow our students to come back to this should they need to. Do you have any other insights on the spinal cord anatomy, Christine?
No, just it can be helpful to refer back as you're learning maybe about different spinal cord injuries, and it will make more sense if you reference back to this information. So this is more just foundational to help you understand what the effect of a spinal cord injury at a certain level might be.
Yep. All right, we also have our peripheral nerves. There's 31 spinal cord segments from the human spinal cord, 8 cervical. We have 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. So all exiting through the neuroforamen and then becoming a nerve and innervating wherever it needs to go from there. And we get to look at those where as they exit the spinal cord, we can look at the dermatomes and myotomes. The dermatomes are the sensory distribution of each spinal level. So when we talk about this, we look at this map here. If we looked at C4, we can see the shaded areas of where that C4 exits each side of the spinal cord and the sensory areas that it covers. The myotomes are the muscular innervations of that. So if someone had a L4 nerve root issue, either because of a herniated disc or stenosis or some sort of other physical injury, they would have weakness in their quadriceps. So we get to start piecing things together as we start seeing it.
And then I would also add, I don't know if you've said this, but depending on the level of the injury, everything below that in a complete injury would be affected.
In a spinal cord injury, yes. Right. Yeah, and we'll talk about that more when we talk about spinal cords itself. But yes, if we looked at the dermatomes chart there, if someone had a T8, I think T8's a little blurry. Let's go T6 spinal cord injury, a complete one, the person would lack sensation from T6 and below. So we could just cross out all of those sensory distributions on that person. And then we could go to the myotomes, and then we could see which muscles would also be impaired as well, anything below the level of T6. So yeah, that's a good point. All right, so that is the big anatomy and physiology, some physiology review. Again, it's mostly here as a reference. The big things to understand: the brain lobes and their functions, making sure we're not overwhelmed by tracts of the spinal cord, and that understanding that it's just a specialized area that's job is just to do, a certain sensory or a certain relay a certain movement pattern. So hopefully that's not too overwhelming. And again, most of this stuff is review and is here for students to refer back to as we dive into pathologies. Any closing thoughts?
No, I'm looking forward to getting to the pathologies.
All right, perfect. All right, we will talk about pathologies in just a little bit.